Welcome everyone to Research and Innovation at ELFT. Thank you for coming. Don't be shy, come on in, get seats as we're going. We're going to try and keep very much to time because we have an awful lot to share with you today. It's not advancing for me. Oops, no, it's advancing that, but not these slides. Oh. There we go. There we go. This is the first time that we are doing both a live in person and a live streaming. So please bear with us with a little bit of the technical difficulties. So the first thing I'd like to talk to you about is making space for research in our daily routine. So why would we make space for research? Well, for one thing, it helps us to develop and evaluate novel interventions and improve the health outcomes of the people that we care for. Service users like being involved in studies. The surveys that we do of participants in research show like 90% returns that they had a positive experience and that they would do it again. It helps make the trust a more attractive place to work. It offers opportunities for professional development. And it can help us win new contracts. There are many different kinds of innovation tools that you can use to help improve. There is research, where we go and explore and try and add new evidence. There is quality improvement, where in a collaborative and iterative way, we improve our processes. And there are many, many other tools. Audit, where we check to see that we are meeting the standards we set for ourselves. Systematic review, where we look for patterns in the evidence to apply locally, or even learning from a single case study review. So how do you get involved? One of the best emails that comes into my box is, how can I get involved? And my favorite answer is, become a research champion. Research champions at ELFT act as role models and activists. They're championing the innovative work taking place in their locality and their directorate. You encourage colleagues to be aware of the work that's involved, and you can help identify to us in R&I the people that are interested and signpost them to where they can find more information, advice, and resources. We look for representatives from every clinical area, locality, and professional group. And we've been doing this initiative for about a year. And what I'd like to do today is to thank this year's champion of research champions. So over the past year, Susham Gupta, who's a consultant psychiatrist at City and Hackney's Early Intervention Service, has been incredibly active working with the R&I team, helping give us really constructive feedback about how we can provide better support. He's been helpful setting up studies and rolling into studies, and he's even published a couple of papers. So we wanted to say thank you, congratulations to our champion of champions. He's here today. I know he's coming today. He just must be there. He is. I have a little certificate to give you to say thank you at the end. So, but thank you very much for all of your hard work. So what's new over the past year? Well, there's been another grant awarded to the Trust, which is being led by Professor Steve Gillard at City University, from whom you will hear more during this afternoon. We have also added 3 new clinical academics working in areas where we've had less research activity. And actually, you'll hear about some work from each of their portfolios over the course of this afternoon. We've embedded lived experience into the R&I team. We have a new R&I microsite to hopefully provide a better way to help you see what studies and training is available. And speaking of training, we're starting very shortly fortnightly training sessions, skills series to help you with different research methodologies, how to plan, how to write bids, etc. So look for that on the website and you can sign up for those sessions. So what about today? Today is the familiar formula of very brief presentations on a range of topics from speakers both from within ELFT and our university partners. And then during the refreshment break, there will be an opportunity to network with some of our research support partners and talk to them about how they can help you get your research started at ELFT. Some of the changes for today is that we are both back live, yay, after COVID, but we are also doing a hybrid service where we are live streaming this to all of you folks at home. And we want to bring that live streaming audience to have the opportunity to participate today, which means that we're going to be taking questions through Menti. So please, everybody, follow that link on Menti, get set up. That is going to be the way to submit your questions, both at home and here in the room. And the chair they will be coming right up here on our screen, and the chair will be able to present those questions after each speaker has finished speaking. And with that, I'm going to cede the floor to Steve Gillard, who's going to be chairing the first session.
Thanks very much, Karen. It's lovely to be back in person talking about research and learning about all the research you've been doing in the Trust over the last year or so. My name's Steve Gillard. I'm Professor of Mental Health Research at City, University of London, just up the road. We're one of the Trust's university partners, and we collaborate on a lot of research projects together. I'm going to keep my introduction to a minimum, though, because time is very tight. So I'm more or less just going to be introducing speakers and then fielding questions. If you are a speaker, you've got 5 minutes to speak. You'll get a 1 minute left sign, and then a please finish. And please finish doesn't mean do one more slide. It means stop talking and we'll take questions. So with that, I'm going to introduce our first speaker, who is Eleanor Keiller. Eleanor is a drama therapist and a PhD doctoral researcher based in the Youth Resilience Unit at Queen Mary. And Eleanor's project that she's presenting is around the drama therapy intervention to alleviate mental distress with children and adolescents. I'll leave you to introduce that.
It's basically just on my first slide for me, so thank you very much. Can everyone hear me okay at the back? Yeah. Right, yeah, that's me. So hi everyone. As Steve said, my name is Ellie. I'm a drama therapist and a PhD student at the Youth Resilience Unit.
Karin,
sorry. Okay, thank you. And I'm going to share with you today some results of a systematic review that I've been working on since January. I always find it's really helpful to start with a little bit about what drama therapy is. So drama therapy is a creative form of psychotherapy. It sits alongside art therapy, music therapy, and dance movement psychotherapy. You may have heard of those before. In drama therapy, we use various elements of drama, so maybe puppetry, character, story, movement, and we use these to facilitate the psychotherapeutic process. So why am I here? As a drama therapist who was a clinician before, why have I come into a research role? Well, drama therapy is really under research. We're about 50 years old in the UK, and our evidence base is just moving into really kind of I think an exciting empirical space. What we do know about drama therapy is promising, but we do need more research. Hence my thought that drama therapy may be a useful treatment for children and young people with emotional distress. So as I mentioned, I'm going to talk about a systematic review, and this is of drama therapy interventions that are used to alleviate mental distress in children and young people. Mental distress for this topic are conditions and symptoms of anxiety, depression, and trauma, and papers that were related to the reduction of those symptoms were included in this review. So this review is the first of its kind. So we started out with 2 research questions that really scoped the drama therapy that's out there. So what are the people who are in drama therapy? What are their characteristics? And what are the intervention characteristics? So what does the drama therapy look like? How many sessions? Where is it taking place? Etc. The third research question was about the effect of drama therapy and whether we could calculate a pre to post intervention effects. We've got a delayed clicker. There we go. So I'm just going to talk briefly about the method. We searched 7 databases and did 3 hand searches of journals, which led us to 4,604 sources. We screened those and ended up with just 15 suitable interventions to include in the review. Of those 15, 5 studies were quantitative, 4 were qualitative, 2 were mixed methods, and 4 were case studies. Just to draw attention to the 5 quantitative, 3 of those were RCTs. So 1/5 of our studies were RCTs. Results then. So research question 1 and 2, where we looked for intervention and population characteristics, showed us that there was no typical drama therapy participant and no typical drama therapy intervention. There was a lot of variety. Despite this variety, we were able to draw out some patterns. 1/3 of our studies took place in schools. 1/5 of them took place in clinical settings, so that was inpatient and outpatient. Nearly all of the studies related to group drama therapy, so 13 or 15 studies. And where groups existed, they were often mixed diagnoses groups. So there wasn't your anxiety group, your trauma group, etc. It was lots of different diagnoses or no diagnoses within a group. Where there was a group, it was often, where there was a group with a kind of common experience, it was often that the group had all experienced the same traumatic experience. So you'll hear about some studies that one of them was following a school shooting and one was following sexual abuse. Research question 3 then, looking at the effect of drama therapy, we found large effects for drama therapy following trauma, and that was in that school shooting and sexual abuse paper. And these studies were similar in that they delivered drama therapy to adolescents in longer sessions and for 8 sessions. Drama therapy for high-level symptoms, so clinical symptoms of emotional distress, showed us medium to large effect sizes. This was participants who were in a hospital for anorexia and in CAM services. And these participants were largely adolescent females, and they had drama therapy for weekly. Medium to large effects and small to medium effects were found in drama therapy that took place in schools. But interestingly, the larger effects were seen in teacher-reported data. Self and parent-reported data in the same intervention showed us slightly smaller effect sizes. And this was for primary school-age children, where the drama therapy took place weekly. I really want to stress the methodological limitations of the studies involved in this review. There were very small sample sizes. There were very few control groups. Only 3 of them were randomized control trials. 1 wasn't truly randomized, and they were not blinded. With that, our findings are that drama therapy may be effective for adolescents who have experienced trauma, adolescents with high-level clinical symptoms, and children who are in need of early intervention support for emotional behavioural difficulties. Thank you so much for listening. Thank you to Barts, to my funders, and to Missy.
So I'm a consultant paediatrician and named doctor for looked after children in Newham. I work in SCIPS. We piloted a new pathway with the help of funding from Barts charity for an integrated healthcare pathway for unaccompanied asylum-seeking children. But thanks to Michelle Hayes and Alice Armitage, who procured this funding. For those who don't know, although it has been in the news this week, and Suella Braverman is not my favorite person right now, unaccompanied asylum-seeking young people are under 18-year-olds who travel to this country, escaping war, torture, all sorts of things, and have experienced significant trauma, either at home or en route. Because they're under 18, when they enter this country, they enter into the care of the local authority and become a looked after child. And this is where we get involved. The pathway came at that. I'm going to just, first of all, sorry, this is just to give you a flavour of how many young people we see in Northeast London. In Newham, we see probably the most because the Home Office, there's a few hotels in Newham where they come through. The numbers are increasing, and Newham's population represents about 1% of the unaccompanied asylum-seeking children nationally. So this integrated pathway was developed after, sadly, 4 young people took their lives in Camden. And the unaccompanied asylum-seeking young people, there was an investigation and a review of the healthcare that was provided for these young people. And from that, it was understood that we should be this initial health assessment, we should be trying to provide them with a holistic assessment, addressing not just their physical health needs, but their emotional well-being, thinking about their sexual health. And this included signposting to sexual health services and doing some infectious disease screening, but also, most importantly, having a mental health professional there at the initial health assessment, which wasn't previously the case, and a health improvement practitioner who facilitated some of these outcomes. So this is what we did. It was started in Camden, and this is what we replicated in Newham. We have an initial assessment, which lasts about 2 hours, and then it's followed up in about 6 to 8 weeks with a multidisciplinary meeting where we follow up on our recommendations and support care planning with the social worker. And so the CAMS clinician health improvement practitioner are all involved from at the initial assessment. So we did a baseline review of the UASC we were seeing before we implemented the pathway in the year prior. This was October 2019 to October 2020. We had seen 26 young people, majority male, majority of the older adolescents, significant number, over 20% had disclosed physical abuse. Probably a lot more had experienced physical abuse. And also about a third had reported symptoms of post-traumatic stress disorder and other symptoms of mental health distress. However, only a few had been referred for further support to CAMS services. Thinking about the physical health outcomes, we looked at some of the things that are statutory required. So we looked at dental health, infectious disease screening, and sexual health. So we did pretty poorly before this pathway. So after we implemented the pathway, you can see that we significantly, well, I know we didn't do statistical testing, but we improved. We did quality improvement, iterative monitoring of these quantitative physical health outcomes. And we found with our run charts that we were improving every month on month, but overall, we were doing better in all of these areas. Our CAMS colleagues also looked at mental health outcomes. We're getting a better pickup of these mental health symptoms and distress. And we had 10 referrals to CAMS out of 33, and also picked up quite early on suicidal ideation and self-harm. And also importantly, we got great feedback from we gave questionnaires out at the end of every clinic. And these are some of the comments that we got from UASC themselves, but also from professionals who attended the multi-professional meetings for 6 to 8 weeks. So what we're doing now is literally last Thursday, I've submitted for a grant to expand this pathway across North East London. So across 7 boroughs to cover about 230 UASC over 18 months. And along with it, doing some qualitative feedback with UASC directly. We couldn't do that this time because of COVID and getting ethics. But we hope we'll be successful next time, and doing a cost effectiveness analysis as well. We were lucky that the pilot got co-opted into the Newham CCG, will continue to fund it. And we hope that the NEL ICB will continue to do the same. Thank you.
Perfect, thank you very much.
No worries.
Well done, you'll be able to stop there. Any questions? What? I'm trying to scale up this.
Thank you. So it's for a start, it's understanding the numbers. I think is going to be our biggest challenge, even in Newham, because of the changes in our Home Office policy and the numbers that are coming in. We're not able, I think, being able to meet the demand is going to be very tricky. We already in Newham, we're unable to keep up with the demand, and we're having to see some off the pathway, which is really unfortunate. But as much as we're trying to mitigate against that by having discussions with CAMS still, even if they aren't able to be at the present at the initial health assessment. Yeah, so I think for us, I think demand is going to be the biggest issue.
Another question there, does the integrated pathway include any specific suicide prevention steps?
It doesn't at present, but what we've as part of the scale up, not specifically suicide prevention, but we're going to do some workshops using Tree of Life, which I don't understand because I'm a pediatrician, but the psychologists have been teaching me about, and so doing some narrative therapy work with them. Yeah, it's a good, so I guess at the initial health assessment, we're screening, we're giving lots of support at the MDT. We have an ongoing, we're very lucky in Newham that we have a LAC CAMS service. So these, outside of the initial health assessment, we have a CAMS service that supports these young people and the social workers. So then they will have an awareness of this service from the start, and we can continue to support and signpost these young people throughout the time period in which they're in care.
Next question relates to Karin's point earlier about increasing PPI.
Yeah.
So,
it is written into our grants, all over our grants, and yeah, absolutely, it's a significant thing that for our new grant. And we were trying to do it. So we were going to do qualitative focus groups, first of all, and we were going, COVID just destroyed everything that we were trying to do and time. But yes, definitely with the grant, we've got
Young people presents different challenges.
And with UASC, with the language barriers, it's even more difficult. So it's sort of, we did have a young person, UASC, who helped with recruitment, and they did help advise on the pathway in Newham. So we had some involvement, but not as much as I would have liked.
Just as a point, funders never seem to query how much PPI you put in a grant. So it is important to resource it.
Yes, yes.
Yeah. Okay, Sveta, thanks very much.
Thank you
for that. We're keeping to time. It's exciting, isn't it? Okay, our next presenter is Milena Nikolajeva. Milena is a PhD and a research assistant, sorry, in the Youth Resilience Unit again at Queen Mary, and is going to talk about the DEAR study.
Thank you. Can everyone hear me at the back? Great. So, hi everyone, my name is Milena, and I'm here to present the DEAR study, which I'll talk about shortly. But first, I'm going to talk about the background associated with it. So, we would like to look into resilience within the DEAR study. Now, what is resilience? This is a dynamic, plastic, modifiable process by which people manage their mental distress and maintain positive mental health. And this can be defined in a myriad of different ways. And this can really be influenced by both individual and external factors. So things like personality, grit, but also things like community resources that people have access to, their family, and different support groups within their lives. And all of these amalgamate into health-sustaining resources that go on to build resilience. Now, resilience is really important and all of us have it, but although this type of thing starts in sort of pre-adolescent age children, not a lot of research has been done in that particular age group. And especially within East London, which is a historically underrepresented area of research, again, resilience has not really been looked at much. So that is where we come in, and our aims were to better understand what it is about resilience that helps children prevent their mental distress and maintain positive mental health. How do children define their own resilience and what it means to them? How it develops and changes over time, and how all these internal and external resources work together to impact on their resilience. And most importantly, this is a feasibility of conducting a cohort study within East London primary schools. So the development of emotional resilience, the DEAR study, this will be a longitudinal and accelerated cohort study design. We'll be visiting primary schools within East London twice a year, and we're hoping to recruit around 600 children aged 7 to 10 years old across year groups of year 3, 4, and 5. And we'll be following up the children every 6 months and also asking parents and teachers to complete questionnaires once a week to really gain a holistic sense of what resilience may be, both in terms of the perspective of the kids, but also their parents in their lives and teachers. Before we started our recruitment process, we conducted a consultation process where we spoke to mental health professionals, academics, and teachers who could help us develop any ideas about what sort of things we should be looking at in such a big cohort study. And one of the main things to come up was the idea of having a holistic sense of looking at what resilience may include. So we're not just gaining quantitative data in this project, but we're looking at qualitative things as well. So for example, we're using body mapping as one of our measures in order to, again, gain that holistic sense, understand what resilience is, both from a numerical perspective, but also what it means to the children. And so far, we've got 14 schools that have agreed to participate. This is a map of East London, and the numbers there represent the number of schools so far that have agreed to participate per borough. And we have now distributed over 1,500 consent packs across 10 schools. And we're going around and conducting assemblies, distributing the consent packs. So that number will continue to rise, and we will soon begin baseline testing. In terms of next steps, we're looking to work with the schools to explore ways of how best they can include the topic of resilience and mental health within their curriculum to engage the children and the teachers more about mental health and how to improve resilience. We'll be hosting termly school mental health workshops with teachers and academics and mental health professionals, and the Youth Resilience Unit was established in March 2021, so we'll finally be having our launch event on the 16th of March, so keep your eyes peeled for that. And at the moment, in terms of challenges, we're looking to explore additional recruitment strategies, because this is something that we're sort of finding challenges with in terms of having such a big recruitment target in a historically deprived area. How do you engage the parents and the students despite particular barriers that may come across? And we're hoping to prepare for follow-up data collection in winter 2023 and beyond. A big thank you from the Youth Resilience Unit and particularly Barts charity, who have helped fund our project and our research endeavours. And I'm happy to take any questions that anybody may have. Thank you.
That was within 5 minutes, I think. Well done. So we've got a question there about showing some examples of outcome measures that we use to measure resilience. And I had a related question, which is, what is body mapping and what does it tell you about resilience?
Sure. So in terms of the outcome measures, to just answer that firstly, we'll be gaining lots of different ones. So for example, looking at things like weight, height, looking at ARCADs, so looking at anxiety, depression, and social anxiety scores. We're looking at different facets of mental health as well. So things like facets of PTSD, but obviously not clinically because they are still young, very young children.
And
but
those
also
are parents and teacher rated scales.
and also self-report. So we're using validated measures, but some of them, as again, this is a feasibility trial looking at how to run the cohort study. Some of the measures we're hoping to pilot in slightly younger children, because a lot of them have been rated in 8 years and older. And as for body mapping, this is an arts-based measure where you ask a person or a child in what region of their body do they feel stress or particular targeted emotion most. So then they have to draw this out on a body map. Okay. And it kind of helps to see embodied experiences. Actually, one of the PhD students within the study is here today, and she'll be using that within her project and assisting on the cohort study.
Thank you.
Thank you.
Another question, how are you planning to work with parents who may not be speaking?
This is a very good question, and this is actually something we've come across because, as I mentioned, one of the challenges we came across was to do recruitment. And of course, within East London, you have lots of bilingual and multilingual communities. In terms of engaging with those parents and groups, we're playing around with the idea of using translation services to make sure our source material is available in those particular most spoken languages within those communities, to make sure that we can be as inclusive as we can. And we're hoping to potentially, again, include potentially parent association groups to, again, those parents that are able to speak both languages coherently and well, they'll be able to sort of be that guide and translate well enough to put across the material.
Okay, thank you. Any other questions? We're in danger of getting ahead of time. Oh, yeah. How did you go about successfully getting the support of so many schools in the study? Good question.
So the recruitment process was relatively lengthy but ongoing. Initially, we sent out lots of emails, pamphlets. We did lots of workshops with schools to kind of gauge interest about the topics and particularly the study itself. And myself and my colleagues are going to assemblies within schools. So we're doing school-wide assemblies to essentially engage the children and their teachers about the topic and presenting this as an opportunity to take part in and making sure that the children are first and foremost given autonomy, not being forced to, consent without their wants and things like that. But yeah, I think seeing that in action helps to engage the teachers a lot, because then they're able to see exactly what it is that we're going to do, and they can see that we're putting the children first and foremost.
It's probably fair to say there's less of a research culture in schools than there is within health services. Did teachers welcome the idea?
I think they definitely welcome the idea, and particularly now within the context of what's going on in society right now with the war, climate awareness, the cost of living crisis, resilience is on the top of everyone's minds, particularly in schools, because a lot of children, especially post-pandemic, are suffering. School absenteeism has really gone up, and we need to find ways of engaging pupils more. So I think something like this is actually really welcomed by schools.
All right, thank you very much.
Thank
Well
you.
done. Okay, I'm going to introduce someone who I know quite well now. So our next speaker is Kirsten Barnicot. So Kirsten is a lecturer in health services research at within the School of Health and Psychological Sciences at City, and Kirsten is going to talk about a video feedback intervention, positive parenting.
Thank you very much, Steve. Okay, so I'm going to share with you the findings from 2 feasibility trials of the video feedback intervention for positive parenting conducted in perinatal mental health services in East London and elsewhere. First, just a standard disclaimer from the funders. So we know that supporting positive parent-infant relationships from the start is really important for setting children on a trajectory of positive emotional development. The NHS long-term plan mandates increased provision of parent-infant relationship interventions. However, there is little evidence on which parent-infant interventions are effective, particularly for parents experiencing moderate to severe perinatal mental illness. And there is no randomized control evidence until our work on effective parent-infant interventions for perinatal personality disorder. So we investigated the video feedback intervention for positive parenting, or VIP. This aims to boost parental sensitivity, which is a parent's ability to tune into what their child is communicating and to respond in a sensitive way, which in turn has been shown to bolster secure parent-infant attachment relationships. In the intervention, the parent and child are video playing together, and the clinician then plays the video back to the parent and comments on the interaction from the perspective of the child. And this aims to help the parent to tune into what their child is communicating. And it also reinforces positive moments in the interaction between the parent and the child. It's an evidence-based intervention tested in over 13 randomized controlled trials in other populations, but hadn't yet been tested in a perinatal moderate to severe mental illness population. So in our first project, we recruited mums who had a 6 to 36-month-old child and were experiencing enduring difficulties in managing emotions and relationships consistent with a personality disorder. And we randomly assigned 20 mums to receive our modified version of VIP for perinatal mental health and 14 mums to receive usual treatment. The mothers were recruited from perinatal mental health services in East London and elsewhere in London as well. So our findings showed that VIP seemed to be feasible and acceptable for the mums taking part, with 95% of those allocated to receive VIP taking part in at least one session and 70% completing all 6 sessions. The mums shared with us that the positive feedback they received from the clinicians on their interaction with their child was really powerful for them. And in some cases, like in this quote here, it was the first time that they'd had someone telling them how good what they were doing was. For some mums, being able to see themselves on video helped to change their perspective on the interaction by giving them a different perspective on the quite negative outlook that they otherwise had. And some mothers spoke to us as well about how the feedback helped them to pick up on their child's cues, interpret them more accurately and respond sensitively. We assessed a number of outcomes, one of which was maternal sensitivity. This was assessed based on videos of parents and their children playing together, which were rated by a psychologist who was blind to who had received VIP and who hadn't. As you can see in the blue line, which is the mums who received VIP, the percentage of mums rated as highly sensitive really increased from before the intervention to afterwards, so from 35% to 64%. Whereas in the control condition, which is the orange line, the percentage of mums rated as sensitive decreased over time from 50% to 33%. The numbers taking part were fairly small as this was a feasibility trial, so we can't say for certain that the differences you can see here are due to VIP, but it certainly looks quite promising and worth further investigation. Finally, in our most recent study, we've adapted the intervention for younger babies who are aged 2 to 6 month olds and carried out a case series in 13 mums using perinatal mental health services. The feedback we've had from mums has largely been similar to the feedback that we gained from the mums of older babies, but the mums have also shared with us that they do feel the younger age range is developmentally appropriate for the VIP intervention. So that was good to know. We assessed outcomes again. You can see the parent-child interaction risk and parental stress decreased over time, and mum's confidence in caring for their baby and feelings of warmth improved. There was no control group here, so we don't know if these positive changes would have happened anyway, but again, it's certainly looking promising. Thank you very much.
Hi everyone, I'm going to be speaking today about exploring the needs and priorities of those who care for children with complex neurodisabilities such as cerebral palsy in Newham, East London. This is part of a bigger study called Encompass, and I'll be talking about the first aim, which is the needs and priorities. But other aims of the Encompass study was to look at the feasibility and acceptability of adapting the Ubuntu intervention for this context. And this is a community-based caregiver training program intervention. Those are a lot of words, but it was developed in low-income countries like Ghana, Bangladesh, Uganda, and we will be looking at co-adapting it for the setting in Newham. But today I'll just be talking about the first aim. So we had 18 participants in total. There were 6 healthcare professionals and 12 parents and carers. They mostly had children with cerebral palsy. 2 rounds of semi-structured interviews were conducted with each, and the data for this aim was analyzed using an inductive thematic approach. 3 themes were developed, and I will go through each theme now and give you some illustrated quotes too. So the first theme relates to caregiver mental health, and all parents and carers in the study spoke about difficulties with mental health, whether this be anxiety, low mood, denial around the diagnosis, feeling overwhelmed about the multiple appointments and tasks required of them, worrying about what the future would look like and what the future of their family would be, feeling isolated as seen in that first quote. And this relates to friends and family not necessarily understanding their situation. And a few participants discussed how it took time, sometimes years, to understand the system and to feel okay. The second theme, a thirst for knowledge, speaks about parents finding it difficult to understand what is cerebral palsy and the accompanying comorbidities. And this relates to the second quote, where this parent speaks about the medical jargon that people in the NHS use and the different acronyms and difficulty picking these apart and understanding them. Also not knowing what different healthcare professionals do and how to access all these different types of support. This led them to conducting their own research, often on the internet, and this was sometimes led to difficulty sifting through this and knowing what was true or relevant or helpful for their situation. There were some interesting tensions around empowerment, as healthcare professionals wanted to impart knowledge and let the parents go on and do, whereas some of the parents described how they wanted a bit more hand-holding and to be told what to do or to be sort of walked with on their journey. So something interesting to explore there. And the final theme was a need for holistic support. And I think this quote is very powerful. It's a woman who walks into an appointment and her child receives a diagnosis of cerebral palsy. And she says, there was no support, there was nothing, not a telephone number for a support group, just absolute darkness. And I think this speaks to the absolute desperation of parents in this particular situation in key transition periods around diagnosis, but other transition periods are starting school or transitioning into adulthood. And this was reported by both caregivers and healthcare professionals. Others reported the need to connect with others with lived experiences and the need to improve overall communication and coordination between services. And this also involves the wider community, such as schools. So just to think about some key messages from this aim of the study was that the delivery of health services for this population really needs to encompass the broad needs of the family while still meeting the clinical needs of the child. Parents need clear and up-to-date information. There's a need to improve the overall coordination and communication between all these different services. and a need to encourage the formation of peer support networks so that parents and carers can really connect with others with lived experience and to feel less isolated. And what next? As Steve said, I'm just started my PhD, and what we'll be doing now is co-adapting this Ubuntu intervention for this context. So working with healthcare professionals and parents and carers in Newham. We'll briefly pilot test it to assess the acceptability and feasibility. And after it's written up, and we'll hope to do sort of a larger scale evaluation. And the aim of Encompass is really to try and meet these unmet needs and priorities of those who care for children and young people with complex neurodisability. And there's the research team. Thank you. Oh.
Kirsten, thank you very much. There are lots of questions coming in. So which other neurodisabilities, if any, were involved in the study, and what's the difference between those?
Oh, yeah. So I think there was 2 participants who it just said complex neurodisability in their sort of background data. It wasn't picked apart if there were differences between this and those that were diagnosed with cerebral palsy. But a lot of children in this context are actually diagnosed quite late, or sometimes don't even receive a diagnosis, which brings a whole host of other difficulties for the family too.
Yeah, and I guess that relates to the next question. So what support structures are already in place, and what are the barriers there?
So I think obviously there are the healthcare professionals, the physiotherapists, occupational therapists, speech and language, pediatricians, parent support groups, and sort of SENCOs in schools. But I think it's just about how do all of these different supports join together and provide support.
There's a question asking for a bit more information about the Ubuntu intervention. So lots of people are kind of doing global research now, global health research, because there's new funding streams. Quite often that involves adapting things developed in higher income countries into lower income contexts. You're going the other way around.
Absolutely.
Tell us a bit more about that.
Yeah, it's sometimes termed reverse innovation, but we are adapting from a low income context to a high income context. Ubuntu is a group sort of interventions targeting children with complex neurodisabilities. It's a modular program, so there's 10 modules looking at educating parents and carers around different aspects of caring for a child with cerebral palsy. Group programs, so it involves sort of supporting those support networks. And some of the modules actually look at the wider community. And so looking at what are the support structures out there besides sort of those in health services. So looking at signposting to various services in the community and reducing stigma, bringing family members in. There's loads to it, but yeah, I don't know if that explains a bit of it.
Yeah, and any of the data you've collected, how does that compare to data about Ubuntu, where it was developed?
Oh, good question. Most parents and carers and healthcare professionals in the study were very interested in how this could be implemented in this population and showed quite a positive reaction to it. We also gathered practical suggestions from both parties about how we could do the adaptation, and it will be adapted alongside parents and carers and healthcare professionals. So it looks promising, but we've obviously got a lot to figure out and to see if it will work.
And someone asked, how will you help to ensure implementation of any recommended changes? Have you got the data you need to do that, do you think?
Not yet. No, I think we're very much in the early stages. I think it's about really focusing on training the facilitators to carry on the intervention, but it's also really about embedding ourselves within the context and really trying to get sort of key enthusiasts involved that might want to carry the program on later on.
Are you going to be doing any similar research with professionals?
Can you explain what you mean?
Well, around implementation.
Yeah, so in terms of the professionals who would be implementing.
Yeah,
Absolutely. So we would like physiotherapists, occupational therapists, as well as expert parents and carers to deliver their intervention. Yeah.
Okay. Any other questions? Okay, thank you very much.
Thank you.
Okay, we're nearly there for the first half. So can I welcome Afia Ali next? So Afia is a consultant psychiatrist in learning disability in the Trust and also honorary senior clinical lecturer at the Unit for Social and Community Psychiatry. And you're going to be presenting on cognitive and behavioural interventions for reducing aggressive behaviour.
Yeah,
thank you.
Thank you. Thank you. So I'm going to be talking about a Cochrane systematic review on behavioural and cognitive behavioural interventions for people with aggressive behaviour and intellectual disabilities, also known as learning disabilities in the UK. So about 8.3% of people with intellectual disability living within community settings will display some form of aggressive behaviour, and that can have negative consequences for the person. So for example, that may increase their exposure to restrictive practices such as restraint. They're also more likely to be given inappropriate psychotropic medications, particularly antipsychotic medications, which can have adverse side effects. But also they're at increased risk of their accommodation breaking down and of being admitted to psychiatric hospitals. In fact, challenging behaviour is one of the commonest reasons why people with intellectual disabilities might be admitted to a hospital. And actually reducing hospital admissions is a key priority of the Transforming Care agenda, which rose as a result of scandals within inpatient settings such as Winterbourne View, but there have been a number of other scandals since then. Now, the NICE guidelines recommend two types of interventions for challenging behaviour. One is positive behavioural support, or PBS, which is a type of behavioural intervention, and the other is anger management, which is based on CBT. And the focus of this review was to evaluate the effectiveness of behavioural and CBT-based interventions specifically for aggressive behaviour in people with intellectual disability. And we included both children and adults of any severity of intellectual disability, and we included any type of behavioural and CBT intervention. So these included PBS and anger management, but also included other interventions such as mindfulness and dialectal behavioural therapy, amongst others. And our comparison groups were any comparison groups, really. So we included no treatment comparison groups, including as well as waitlist control groups, treatment as usual, and also standard treatment. So we were interested in a range of different outcomes, but our main outcome of interest was changes in aggressive behaviour measured using a standardized measure, or any changes in the recorded number of incidents of aggression. But we were also interested in things like changes in adaptive functioning, psychiatric symptoms, quality of life, and also costs to services, costs to the NHS and social care. Primarily, we included RCTs within the study, and we searched a total of 13 electronic databases from inception to March 2022. And we had two authors who independently screened all the records. They independently extracted the data and conducted the risk of bias assessments for the studies. And we used the grade approach in order to rate the certainty. So essentially, it's looking at the quality of the evidence for each outcome. And the evidence was rated according to whether it was high, moderate, very low, so high, moderate, low, or very low. And where possible, we pull the results into a meta-analysis. Okay, now this was actually an update of a previous systematic review, which we published in 2015. For this update, we identified 9 new studies. So we had a total of 15 studies altogether, comprising 966 participants, of which 6 of those studies were behavioural interventions, 3 were in PBS, 7 were CBT-based interventions, of which 4 were in anger management. And then we had 2 studies that used sort of a mixed approach. So, and they were primarily looking at mindfulness-based PBS. And this is a summary of the main results. So for positive behavioural support, we found evidence of moderate certainty based on results from 2 trials that PBS reduced aggressive behaviour in the short term. And that was post-intervention at 6 months, but not at longer follow-up at 12 months. And there was no other benefit for any of the other outcomes. For anger management, we found evidence of moderate certainty from one trial that it reduced aggressive behavior, again in the short term, at 16 weeks, but not longer term. And there was some evidence, but lower certainty evidence in relation to anger management improving ability to control anger, as well as adaptive functioning and psychiatric symptoms. In the case of mindfulness-based PBS, we found evidence from 2 small trials of low certainty that it might reduce incidence of aggressive behavior. So what are the kind of implications, clinical implications of the study? So there is growing evidence that behavioural and CBT-based interventions might be effective in the short-term management of people presenting with aggressive challenging behaviour. But currently the evidence for medium and long-term benefits remains lacking. There's actually no evidence that either interventions improve quality of life and are cost-effective. And that's quite important given that the NICE guidelines recommend these interventions as first-line management in the management of challenging behaviour. There are issues around service provision. So PBS is meant to be widely implemented in services, but actually sometimes it is quite difficult to access because of long waiting lists. And anger management isn't actually widely available in patients with learning disabilities. Now, the review does suggest that there might be some cumulative benefits of actually combining interventions and actually having multi-component interventions. So that's perhaps something that services need to perhaps look at trying to address, or trying to actually give people, provide access to more than one intervention. So the implications for research, so most of the studies were actually small and had methodological limitations. And the sort of main limitations were that often the outcome assessors weren't blind to the allocated groups. The measures that were used to look at changes in aggression were often based on kind of a general measure of change in behavior. So really future RCTs really need to be better quality, be larger, and in particular, they need to focus on things like quality of life and costs, as well as changes in aggression. So yeah, that's it really, and these are the references for the manuscript, which is currently under review, but we're hoping for it to be published in the next couple of months. Thank you.
Thank you, Steve. I'm Jacqueline, and I have the pleasure representing Dr. Alan Williams. She's a GP in Newham. Dr. Helen Stafford, she's a GP Alan is in Tower Hamlet. Helen is in Newham. And then actually we work very closely with Bromley by Bow Center, which have a GP surgery and also have a community research organizations. So the boring title of the whole study is called Improving the Physical Health of Individuals Affected by Mental Illness Through Co-Produced Health Resources. And because of the co-produced approach, I think we come up with something much, much more interesting, starting with the title. And this is the flyers. And this project is actually funded by a very small, tiny health innovation fund that is coming from City University to encourage partnership with third sector organization or industry, aiming for actual impact in improving health in the society. So most of the totality of the funding gone into Bromley by Bow will include community researchers. And what we're aiming to do is to find out from people who actually has a severe mental illness, i.e. psychotic disorder, and they have like much higher risk of having cardiovascular disease and die prematurely, nearly for 20 years compared with the general population without a severe mental illness. And we also want to work with primary care and community organizations like volunteer, like social prescribing workers, GP surgeries, etc., to find out what are the problems, what are the needs, and can we produce some materials in whatsoever form that can help to address the problems. So through working with Bromley by Bow, who actually do most of the research activities, even though the whole team work together, we have actually community researchers, 4 of them, and we have 2 people with lived experience, and then Helen, Ellen, and myself as a professional. But we have like the non-professional outnumber the professional members in the team. And in the first phase, which lasts for 5 months, which is pretty good going in terms of research studies. So we got ethics, we got recruitment, and we recruit 35 people either with lived experience themselves with a severe mental illness, or people working in the community, to come to 5 different focus groups. They were offered face-to-face in community venues, like in the local Mind center, or virtual by Zoom or by Teams meeting. Actually, quite interestingly, in the community support worker population we recruited in the study, quite a lot of people themselves have lived experience of mental illness. It may not be psychosis, but a lot of people were kind of like feel like they're paying back to help other people's to get physically healthier using their own experience. We have a lot of people working in social care and working as social prescribed workers that take people out for problems such as social isolation, being inactive, feeling lonely. And the second phase, which now we've done all the yellow. So after that, we put the results into analysis and come up with some themes I'm going to show you. And then we invited more community members and actually people with lived experience to help us to co-produce what materials to help to address the problems we find. And now currently we're going through the green phases. So materials have been drafted and actually some of them been finalized, but we want to test it out and just to see whether it works before we have a major launch event. Okay, so the focus groups tell us that actually people have a lot of concerns about medication side effects because people with psychosis take antipsychotics that cause quite often weight gain and other problems. People feel quite a bit of injustice, having difficulties to assess service and the power imbalance with health professionals, and sometimes being passed between the GPs and the psychiatrists, whosoever won't change the drugs. So we decided to produce something which is fun, very visual, on multiple format, online as well as hard copies. So this is the kind of overall information leaflets we're going to produce. And you can see that actually the co-production drive it to be very positive, health focused. It's not particularly talking about symptoms or problems, but help people to think about everyone can look after their own health, can do something about it. And other resources, it's like a pack of playing cards. And the GP and our people with lived experience produce it together. Essentially, Helen and Ellen are sharing with people with lived experience of psychosis about how GP service is being set up, how GPs are being trained to conduct the interview, so that people can plan how to use the time, how to ask for longer sessions, be encouraged to go back if they're not satisfied with the GP appointment. And lastly, this is kind of a positive health goal setting material, but in a very fun way. It's like the fortune teller folding paper. People can play around with that, and then it will sprung out something on different sessions. So some of it is telling people to set goal. Some of it is encouraging them to start a new activity, maybe joining a walking groups. Some of them is asking them to look after their own physical health, etc. So we are actually finalizing this and 2 more meetings with the Mind community group to test all this out and make sure they're engaging. Thank you.
Well, thanks very much. A couple of questions there. So did you find that the barriers and ideas from, I guess, the people in the focus group, people with lived experience, were similar, or how did they compare to people working in SMR?
Actually, I think because most of the people, the workers are actually community-based, so they can be volunteer, they can be working in GP or social care as a social prescribing workers. They're all very empathetic. And it was quite surprisingly that we found out through the focus group a lot of them actually have lived experience themselves, which they may not really share in the work setting. People are really, really quite empathetic, and people really kind of understand about how difficult it is for anyone like trying to lose some weight, trying to stay healthy, struggling with mental health as well. So actually it's quite a lot of commonalities there.
Okay. Any challenges in delivering the groups?
Actually, it was quite interesting because it was mostly done by the community researchers involved by both. So Ellen and myself do join some of the group, but we're clearly not leading it. It's just really quite mind-opening in terms of how they run the groups, and people feel very encouraged to participate. So I wouldn't say there was much challenges at all. It's just a different way to run groups.
How do you think the data you got, how do you think it turned out differently compared to if you delivered the groups and say recruited people from within mental health services?
I think it's really quite clearly reflected in what is coming out. I would not imagine if it was led by professional, we wouldn't come up with this, we wouldn't come up with this. It will be less, people will feel less forthcoming, or maybe they may well be the same forthcoming about talking about the unhappiness or feeling not being listened to, but it was much more free flowing, and people want something, it's much more visual, something they really want. They will use. Yeah.
And there's a question there about adapting the resources to a diverse community.
Yeah, definitely. That was very much in mind from day one. Yeah.
Do we have any last question from the room? Okay, thank you very much.
For those of you I haven't met, I'm Claudia Cooper. I'm a professor of psychological medicine at Queen Mary's University, London. And since June, I have been leading the Centre for Psychiatry of Mental Health at QM, which is very invested in ELFT and works very closely. In fact, 2 of our 3 units of the centre are actually based at Newham Hospital. So without further ado, we will move on to our speakers. Just a couple of bits of housekeeping first from Karin. If you haven't registered, you need to register, particularly if you're a junior doctor. Yes? Yes. Yes. And also, when we come to questions, feel free to use Mentimeter. Have I given it the right name? Menti. But also, if you're in the room, please feel free to be traditional and put up your hand. Right. So our first speaker is from the Unit for Social Psychiatry in Queen Mary. Delighted to welcome Agnès Chevalier, who is the Programme Manager of the SCENE study, and will be talking to us today about social influences in psychosis. Over to you, Agnès.
Thank you. So as Claudia mentioned, I am the Programme Manager for SCENE, which is a programme grant looking to develop and test a novel intervention to reduce social isolation and improve quality of life among people with psychosis. But today I'm going to be presenting some findings from the earlier part of the programme, which is looking at the relationship between social isolation in people with psychosis and the areas that they live in. So in the general population, as you might expect, living in a densely populated area is linked with having more social contact. And that finding is pretty consistent, and it remains even after you control for potentially confounding variables such as contact with neighbours. In terms of other characteristics, neighbourhood characteristics, living in a deprived area has been found to be linked with more subjective measures of social isolation, so things like loneliness and also reduced social trust. And in turn, we know that social isolation and loneliness is linked with poor psychological health, poor physical health, and also reduced life expectancy. And people with psychosis, we know, tend to be socially isolated. So they have fewer social contacts than those people in the general population, and also other groups of people with mental illness. In terms of who's more socially isolated than others, we know that being single, being unemployed, and also having more severe symptoms predicts the likelihood that someone with psychosis will be more socially isolated. However, a lot of the variance remains unexplained. And given that we know that in the general population, neighborhood characteristics is able to account for some of that variance, we wanted to see whether that was the case in psychosis. So that's when we did a large cross-sectional survey. So we recruited over 500 people with psychosis from community mental health teams in the UK from a number of different sites, including urban and rural sites. And then we found out their lower super output area. So that is kind of akin to the first 4 letters of your postcode. So it's sort of areas like the UK has been divided up into all these little areas of LSOAs. It only represents about 1,500 residents. So it is quite detailed. It's about, the first 4 letters of your postcode. So that will give you an idea of scale. And from that, we're able to derive certain kind of neighborhood characteristics by looking at the census data, such as the population density in the local area, an index of deprivation, and also the social fragmentation index, which is kind of a measure of how connected people feel to their local area based on how much transience there is in the area, or the also kind of how many people live in like single person households and things like that. So our participants fell into 390 different LSOAs. We also then asked them about their social contacts, their satisfaction with friendships, and collected a number of demographic variables which could confound with the results. So what did we find? So we found that living in an area with high population density to be linked with having fewer social contacts. And if you'll remember from a few slides ago, this is exactly the opposite of what happens in the general population. So there are several kind of hypotheses for why this might be. One hypothesis is that in the general population, you're more likely to have random interactions with people if you live closely to lots of other people. However, these opportunities for random interaction in psychosis might actually be perceived as a threat and cause people to withdraw. Another potential reason for this might be kind of working in the opposite direction, wherein unfortunately stigma might mean that where people live in densely populated areas and they have more choice about the people that they can interact with, they might not necessarily move towards people with psychosis. So in conclusion, patients with psychosis living in densely populated areas are more likely to be socially isolated than those living in less densely populated areas. And this is exactly the opposite of what happens in the general population. We kind of discussed a number of potential reasons for this, but this might be due to the fact that proximity to others might be seen as a threat rather than an opportunity. It's important to note that this study is just a cross-sectional study, so it's a snapshot in time, and longitudinal studies would be needed in order to establish causation. It would also be useful to have some qualitative studies to better understand kind of the mechanisms behind this finding and why that might be going on. And finally, as clinicians who are working in urban settings like yourselves, it's important to keep in mind that despite these increased opportunities for socialization in urban settings, the patients with psychosis that you work with are more likely to be socially isolated. So the findings I talked about today are published in this paper. So I'll leave it there, and then yes, I'd like to invite any questions.
Lovely. Well, thank you. Thank you. That was a really good talk and very clear. Anyone with their hand up in the room? Okay. Now, Agnes, you've got 3 questions already. Would you like to pick?
What do you mind?
Oh, no, you've got 4.
I have to admit that I didn't actually do this study myself, so I'll see what I can what I can answer. But
Why don't you go and go where you can see the board, and then you can
yeah, so in terms of how do you measure social contacts, is it self-report? So the way that we measure social contacts is actually the way that we measure it within the whole SEEN program, which is using this measure called the social contacts assessment. And we're asking participants about the number of social contacts that they'd had in the previous week. So it really is just asking them in the last week, how many social contacts have you had? But it excludes certain things. It excludes things like contacts with family members, contacts with people that you live with. And yeah, that's what we do. It's actually just quite basic.
Wonderful. Okay, now we better try and keep to time. So if you want to pick one last one, and then we'll move on. Or shall I choose?
Yeah, why don't you choose?
Thinking about COVID during that as well, actually. But I wonder, how was the study pre-COVID, or did it account for that?
Yeah, so the study was done. So the data was collected between 2018 and 2017 and 2018. So before COVID, and also the LSOA data that we linked to the kind of neighborhood characteristics is actually based on the 2011 census, because obviously that data hadn't been there on time. So yeah, we can't really get the real-time effects, but it would be really interesting to know what happened during that time.
Yes, I think I can do it again, don't you?
Yeah.
Fascinating. Right, lovely. Okay, well, thank you very much.
This study about the contribution of transference-focused psychotherapy, well known as TFP, in improving psychiatry trainees' attitude and technical confidence toward patients with personality disorder. So TFP is a manualized evidence-based treatment for severe personality disorder based on a psychodynamic approach that focuses on object-relation dyad. And what is that we know? We know that psychiatry trainees are very often first responders in several psychiatry settings, and they meet with people with personality disorders in different services. Nevertheless, there is a documented gap in psychiatry trainee education about personality pathology. So we thought that it was useful to evaluate whether a series of teaching sessions, TFP theory and techniques, as applied to personality disorder, could improve the attitude and technical competence of trainees in the clinical encounter of patient service user with the personality disorder. What was the structure of our teaching? So psychiatry trainees in Tower Hamlet in East London received 4 teaching sessions, 1 hour duration each. We use a mixed teaching like structure, so theory lessons alongside with role plays and debriefing of role plays. And we asked trainees to complete 2 questionnaires before and after the teaching: the attitude to personality disorder questionnaire, addressing the frequency they experience certain feeling toward patient with personality disorder, and the clinical confidence with personality disorder questionnaire that we actually created, not existing like the right tool already, that addressed some key issues identified by TFP, such as like maintaining treatment frame or the 4 main techniques of TFP. We then also conducted a focus group, 1 hour focus group that was recorded, transcribed, and analyzed thematically. And these were the results. On quantitative analysis, our Wilcoxon sign rank test showed an overall improvement in the total PDQ and CCPDQ scores, as you can see in the last p-value column. And also the thematic analysis of the focus group showed that there was an overall positive effect on trainees' attitude and confidence. They said it felt it improved their understanding of the nature of personality disorder, improved their awareness and management of countertransference, and their awareness of object relation and the relation dyad at play in the encounter, in the clinical encounter. So considering that, we can say that we have proof that training junior doctor about TFP theory and techniques can significantly improve their attitude toward the service users and their technical confidence in the clinical encounter. Of note, our workshop is really resource light. It can be easily delivered by remote teaching, and actually it was delivered during COVID. And based on this finding, we suggest that teaching of TFP in the core psychiatric training curriculum should be considered. And thank you to my research group.
Thank you very much. That was a very interesting presentation, and sounds like it was some very interesting training. So unless there's any questions in the room, we have one online. We have two online. Do you know if the improvements have been sustained?
So the structure actually was, we had 3 sessions in 3 following weeks, and then we did like a follow-up session 3 months later. We didn't have enough follow-up data to analyze this, if the improvement was sustained. Actually, we didn't collect enough data to be able to analyze that.
Okay, perhaps there are some people here who actually received the training. They could have told you. Okay, all right. Well, thank you very much. That was a really interesting talk. Thank you. Thank you. Right, so I'm delighted to welcome next Mimi Suzuki, who is a researcher on the Assured study. Now, that's at the Unit for Social Psychiatry, isn't it?
Yeah, and with City University.
And with City University, wonderful. Okay, so you're going to talk about a psychological intervention for people who attend the emergency department for self-harm, aren't you?
Yes.
Thank you very much.
So hi, I'm Mimi Suzuki, and I am the researcher for the Assured study, a NIHR-funded program aiming to test and implement a psychological intervention to support people attending A&E after having self-harmed. So I'll be presenting the preliminary findings from the pilot study conducted in 4 emergency departments. Oops. So there are approximately 6,000 suicides in the UK per year. And self-harm is the highest risk factor for suicide. And while it's only the tip of the iceberg, there are approximately 220,000 self-harm presentations a year to emergency departments. So upon presenting, these individuals receive a 1-hour psychosocial assessment from a mental health practitioner in the liaison psychiatry team. This contact point and the gap between discharge and onward care, where the risk of suicide is greatest, was the focus for the Assured program. So previous literature has shown that the psychosocial assessments are inadequate. Focus groups we conducted in our intervention development stage found that risk assessments were seen to be formulaic and the human connection was lost, leaving the person attending feeling judged and dismissed. So we therefore developed intervention to emphasize listening and allowing the person to tell their story in the assessment through the narrative interview approach, for the patient and the practitioner to develop a safety plan collaboratively and also to provide follow-up care. The pilot study was conducted in 4 emergency departments, 2 of which are from ELFT, so that's Newham and Royal London. And we conducted baseline and 6-month research assessments, as well as practitioner and patient interviews. So I'll be presenting the results for that. So just to note that this is descriptive data and we're only looking at kind of pre-post analysis. So we're not comparing with a control group, so just to interpret the results cautiously. It does provide an indication of how the participants were kind of 6 months after receiving the intervention though. So we measured reattendance to the hospital for self-harm as a primary outcome and found that only 6 out of the 46 participants reattended. There was a reduction in self-reported suicidal ideation and suicidal behavior and improvements in psychological distress. And while the objective measure of social outcomes remained relatively the same, self-reported quality of life outcomes had improved. We also looked at the therapeutic relationship as a potential mediating factor and found that they were both high after the emergency department session, so the psychosocial assessment, and after the final follow-up session. So looking at the feedback from the patients and the trained practitioners for the three main components of the study. So I'll be talking about the ED session, including the narrative interview approach and the safety planning, as well as the rapid follow-ups. So overall, patients spoke about supportive and caring and non-judgmental conversations with practitioners in the emergency department. One patient expressed that the practitioner was genuine, kind, and helpful, a testament to the improved therapeutic alliance. So I'm running out of time, so I'm going to skip ahead. So looking at the safety planning feedback, patients found the safety plan to be helpful and something to trust, but only if it actually resonated with them, and less helpful if it didn't feel realistic to follow in the moment of crisis. The patients generally spoke positively about receiving follow-up support. In fact, one patient unpromptedly said that the follow-up sessions actually helped them to not reattend. And another patient expressed that they had discovered tools within themselves to continue fighting for their health. Likewise, practitioners found the follow-ups to be really rewarding as they were able to kind of meet individuals beyond the one contact in emergency departments. So overall, the key takeaways from these interviews that are somewhat reflected in our data is that the therapeutic alliance in the emergency department should be prioritized, that we should be considering the context when developing strategies in safety planning, and that follow-up care is beneficial and really important. Thank you.
Thank you very much. Another great presentation on a really important topic for our trust. So thank you. We have Dave.
I'm not clear that there's any evidence that doing this produces any benefit. Is that from previous literature? Because obviously people are trying to do the right thing in ED sessions, and there's a bigger picture about what having to keep it self-harm. I mean, the fact that people feel better 6 months after they self-harm than on the day they did doesn't show that the intervention is helpful. So I'm asking if there's any evidence that doing this is actually a good thing.
Yeah, so this is the pilot study where the follow-up period is 6 months. We are moving on to the trial where the follow-up period will be 18 months. So hopefully, we'll find some results from that.
So what will be the design of the follow-up study? Will you have two different interventions? And some people get one intervention and others not?
Yeah, so we'll be comparing with the control group. Yeah, yeah. So yeah, I did put the caveat that this was just pre-post analysis. Yeah.
Okay, thank you. And there's a question. Oh, suddenly a crop of questions. Right. Does this method help reduce need for home treatment teams on follow-up, as is often overused after seeing the patient in A&E? Is there anyone in the room that asked that? No? Okay, right. Well, what would you say to that one?
So I think this does provide an alternative option for practitioners. So home treatment teams obviously one, and it's supportive for crisis care. But yeah, the rapid follow-up care does provide something else. I would just say though that this is slightly different from home treatment team, wherein home treatment team kind of looks at is very brief contacts, and this the actual follow-up session involves solution-focused therapy. So we are testing that as an intervention as well.
Lovely. Okay, well, thank you very much. That was very interesting. So next we welcome Lillian Skilbeck, who is a high-intensity clinician from primary care. And you're going to talk to us, aren't you, about piloting a psychological intervention. So this follows on very well, doesn't it?
It does.
It does. Lovely. I will leave you to take it away then. There's the
Thank you.
clicker.
So today I'm going to talk to you a little bit about our patient-led clinical responsiveness and adaptation research in IM.
So why do we need to adapt intervention and why in IELTS? As you know, IELTS is a very busy service. It's a very sort of high pressure service. And also we started seeing a lot of more complex cases because when IELTS started, it was for sort of mild to moderate symptoms. But so we've started seeing a lot of complex cases and sometimes we haven't known how to kind of work with them. So in line with the sort of NHS public agenda, sort of agenda for change, and also the collaborative empiricism model of IELTS, sort of including the patient, we really wanted to sort of make the patient the center of what we do. And I think this is really captured by this caption from the Lancet, which I think resonates with what we do. So it says here, it is so important to have patients involved in medical research, peer review, and guidelines, because research is really about the patient and what is important to them. Only by listening to patients themselves can areas of most importance be highlighted. And I think with this in mind, I'd like to share a recently published case study. So in IELTS, we're very kind of fast-paced, so the case study has proved to be very valuable to help us understand how to kind of improve our treatment plans. So this was published a few months ago, and it was also the editor's choice because it informed a lot of practitioners. It also, it was funded by NHS England because obviously IELTS has been seeing quite a lot of cases, so they're recognizing that. So this is a case study on PTSD. So the client presented with PTSD, and this was in the context of COVID-19. So the client was a 46-year-old gentleman who had never had any history of mental health problems. So he presented with PTSD. He was in ICU. Prior to that, he had contracted COVID. He was in ICU for a month. He was treated by ECMO. And with ECMO, that's like the last stage of sort of the infection. So the COVID was really severe. He was given a very slim chance of survival, but he survived. And following that, he was having sort of hallucinations, which were reminiscent to the experience in the clinic. So there was a lot of complexity attached to this case. And when he presented to our case, we weren't sure how to kind of work with him. And at the time, there were no unitary guidelines. The NICE guidelines hadn't updated their protocols. So there were no guidelines to guide us. So we adapted our existing model for PTSD. So this is the classic Ehlers model that we use for PTSD. But obviously for this patient, this model wasn't quite enough on its own. Because if we look on here, he was presenting with comorbid long COVID symptoms. So there was complexity from that. He had panic attacks. So he was kind of very hyper aroused to his bodily sensations. So he was having panic attacks as well. He was having depression. So there was a lot of depression around uselessness because he used to work and then he wasn't working. So on top of the classic PTSD symptoms, the nightmares, the flashbacks, the sense of current threat, the avoidance, there was also the added hallucinations, but these were not like psychotic or anything. They were related to his presentations in relation to his ICU stay. So we wanted to conceptualize this, and at the center of this, we wanted to have the patient there with his own explanatory model, because the patient was very clear about what was going on for him. But what was interesting in his case was that he had fragmented memory, so he couldn't remember the whole ICU stay, because obviously he was not in a state to remember. So there were gaps in his memory. So what the patient wanted to do was to involve his own family. So because he was from a very close family, so he wanted his family to be involved in his treatment plan, so to help him fill in the gaps where the memory was sort of fragmented. But also we were working in a very interdisciplinary way, so involving his physical healthcare professionals to make sure that we weren't doing lots of things that would kind of agitate his long COVID symptoms. We also offered him, because in IELTS usually we have 12 sessions, so we had to adapt the sessions, so he had to have 16 sessions. And so it was really, really done with the patient leading, the patient really using his explanatory model of his understanding of the problem, using the existing models already, and then adapting it along with the patient. So the patient was in charge of what he wanted to happen, but also we were guided by the sort of the models that were available. So just through this adaptation, so the key sort of outcomes, at the beginning of therapy, he met the diagnostic criteria for PTSD. He was having depression, he was having anxiety, he was very, very functionally impaired as well. So he wasn't able to work, he wasn't able to leave the house. So through treatment, through the 16 sessions, he no longer met the diagnostic criteria for PTSD. His depression and anxiety had cleared also, and he was back in work. So he started a phased return to work, and at follow-up, 3-month follow-up, he was fully functioning and he was back in work. So in terms of our sort of work, this illustrates a key sort of adaptation that is sort of important, especially when we're working with cases that are not very clear or atypical presentations. It involves the patient at the center and helps us improve our treatment plans to help the clients. It also highlights the importance of interdisciplinary working. And also, I guess in terms of benefiting, like I said already, it benefited a lot of clinicians because a lot of people didn't know what to do in these cases. And obviously the journal editor really wanted to sort of share it out, and it was helpful to people. But it would also benefit maybe people who want to do more research on sort of COVID or atypical presentations. So in the spirit of these adaptations, we have been adapting quite a lot of work using case studies, but we also do qualitative research and also quantitative. But obviously the case study has proved to be very valuable in our IF world. So other adaptations that we've done include working on long COVID, working with combat-related PTSD adaptations there, but also culturally related adaptations to kind of work with sort of chronic depression and anxiety. Thank you.
Everyone. So today I'm going to present a feasibility trial that applied Dialogue Plus for people with chronic depression, and this was a mixed methods trial. So as a background, a lot of you may be familiar with Dialogue Plus, but time precludes me from going into it in any great detail. But in a nutshell, it is a technology-assisted, resource-oriented approach to structure routine clinical appointments between a clinician and the service users that they see. It's used now extensively across ELFT as a care planning tool, but also in many trusts across the UK, in NHS England and Wales, and also globally as well in our low middle income country partner countries. The evidence that underpins Dialogue Plus as an intervention was a trial that was done in ELFT a few years ago, but it was just on people with psychosis. It had great results, and that's why we've seen such wide-ranging implementation, such as improving psychiatric outcomes and cost saving, but this was just for patients with psychosis, and currently there's no evidence for it as applied to people with chronic depression, and this group obviously often have lower quality of life than comparators with psychosis and a high risk of suicide. So naturally, Dialogue Plus might be a good fit for that population. So there are two main components to Dialogue Plus. The first is a dialogue scale, and this is an 11-item quality of life measure, which measures satisfaction across different life domains, and that's completed collaboratively. And these are then used by the clinician to kind of underpin a resource-oriented conversation, which follows these 4 steps to come up with a care plan and action items, which kind of structure the care planning going forward, and those are reviewed on an ongoing basis then. So the TAC program grant, which is kind of my day job, was kind of a 6-year program to adapt and test Dialogue Plus for people with chronic depression, and then establish its clinical and cost effectiveness in a definitive trial. I'm going to talk today about phase 1, which was this feasibility aspect. When you're doing a feasibility trial, it's very important to have kind of preset objectives, and we had 3 main ones. Can we recruit and retain patients with chronic depression into a trial of this design? Is Dialogue Plus acceptable to this patient group? And are the outcome measures that we selected appropriate for this group as well? Well, the first question we answered by recruiting people and retaining them in the study. So across 3 sites in London and Essex, we recruited 10 clinicians, of which 36 patients came from their caseloads. And we had a very high follow-up rate, about 78%, which is around that 80% mark, which you want to see in trials of this design. We had a 2-to-1 randomization, 2-to-1 randomization ratio, and that's because we wanted more people to be in the intervention arm to receive Dialogue Plus, to see kind of what the experience of people with chronic depression was like to receive Dialogue Plus, and 11 were in the active control arm. This second feasibility objective was Dialogue Plus acceptable to this group? And we co-produced a bespoke measure called the Dialogue Plus Experience Questionnaire, which asked questions around usefulness and ease of use and satisfaction with treatment. And we found kind of high levels of acceptability. So 57% found it useful, 64% found it easy to use, and quite a large 86% found were satisfied with their treatment when Dialogue Plus was included in it. We also did some qualitative interviews to explore what kind of the experience of using of Dialogue Plus was like. And often the themes in this analysis were around clarity and focus. So this quote here, this direct quote here, shows us how using the scale and then this force of approach allowed discussions to happen which necessarily weren't happening before. And this holistic approach was kind of opening up avenues and pathways which were previously felt to be closed off. And then finally, were the outcomes appropriate? Well, our primary outcome was quality of life. This is a quality of life intervention, and that was measured on the MANSA. And we actually found an increase in MANSA scores within the intervention group comparative to the active control. And similarly, for the depression symptoms, which were measured on the BDI-2 and the MADRS, we found a reduction in depression symptoms in the Dialogue Plus group comparative to the active control. Obviously, this was a small scale feasibility trial. It wasn't powered. It was a dress rehearsal for a bigger trial. But it was really encouraging to see that these kind of primary outcomes were not only appropriate, but we were seeing small trends in shifting positive outcomes. So what can we conclude from this feasibility trial? Well, we can safely say that Dialogue Plus was found to be acceptable with very little or few amendments needed to the content, and can be kind of translated directly from this kind of psychotic population to a chronic depression population. And there was also initial indication that Dialogue Plus increases quality of life and reduces symptom severity. So as we met all our feasibility objectives, which was very good news for us, we then moved into our definitive trial. So we're now coming to the end of this trial actually, and final results are expected kind of June of next year. So very exciting to see if the results match what we originally found for people with psychosis. Thank you.
So I am presenting on a pre-implementation study of the apple tree intervention. Before I get into what exactly we're doing in the pre-implementation study, I'll just give you some more context on the apple tree study and the intervention. So the apple tree study is looking at a behavioral change, lifestyle-based approach to reducing cognitive decline in older adults with either subjective cognitive decline or mild cognitive impairment. Right now, we are conducting a randomized control trial to look at the clinical efficacy and cost effectiveness of the apple tree intervention. The idea being that if it is proven to be clinically effective and cost effective, it could be scaled up and implemented by NHS and third sector sites. And to give a bit more context on the apple tree intervention itself, it is a group intervention for about 6 to 7 participants in each group. The group meets online over Zoom once every other week for an hour each time for a total of 10 sessions. And during each of the sessions, there are 2 facilitators who go through a variety of different ways to help memory based on the latest evidence. We also have tea breaks on the weeks in between. These are also online, and they're a chance for some informal peer support. And we have goal calls. Those are one-on-one, 1 participant, 1 facilitator every 2 weeks to encourage individual level behavioral change. And the topics that are covered in the apple tree intervention are listed here on the bottom. They include things like a healthy diet, reducing smoking and alcohol, looking after physical and mental health. And the last piece I'll say about the apple tree study is that the facilitators do not need to be clinical staff, but the idea is that they are trained and supervised by a clinical psychologist or a psychiatrist. Now, the apple tree pre-implementation study is asking the question, if the apple tree study is shown to be clinically effective and cost effective, how can it best be scaled up and implemented by NHS and third sector sites throughout the UK? So in order to answer this question, we are conducting interviews with commissioners, service managers, frontline staff at NHS organizations, memory services, GPs, as well as third sector sites, and we're using thematic analysis to analyze the interviews. And so we're still in the process of data collection. So far, we have done 13 interviews with a mix of third sector sites, NHS sites, service managers, and frontline workers. And so for the rest of the presentation, I'll present some of our preliminary findings from just this first section of interviews. So one of the things that we found is participants often describe Apple Tree as a holistic approach, providing a service for people who are experiencing memory problems and might not have a service otherwise, and being able to create a community and reduce anxiety. We did have a minority of participants who expressed concerns about Apple Tree's ability to influence cognition. Often though, these participants still expressed that they felt Apple Tree could be beneficial to the well-being of the people who are taking part. Some organizations felt that they could implement the Apple Tree service easily. They could see it fitting in within their service. Oftentimes, these organizations already ran a group for people with mild cognitive impairment. Other organizations felt that they didn't really have any space or capacity to deliver Apple Tree, but they would instead be happy to refer patients out to Apple Tree being delivered elsewhere. There were often concerns about funding to deliver Apple Tree, how it is currently being delivered in the randomized control trial. So for example, with the 2 facilitators, 10 sessions, and so on. Sometimes participants would suggest reducing the number of facilitators, so having 1 facilitator in order to be able to do all 10 sessions, for example. And lastly, I will just make a point about structure. So most of the people who were interviewed expressed concerns about delivery of the Apple Tree intervention over Zoom. So some people felt that this took away from some of the benefits of being face-to-face. Others felt that this might exclude people who didn't have access to technology. I will also just point out that there were some organizations who would be able to provide technology to people and others who knew of organizations who could provide that technology. And then we just have on the other side, there were some suggestions of how to ensure that the groups are able to accommodate different cultural groups and more diversity. So including things like adjusting recipes for culture, providing resources in multiple languages, and working with community centers to recruit participants from diverse areas. And so we are still in the interview stage. We are conducting interviews through to the end of the year. If anybody here works with people with memory problems or concerns and you would like to take part in an interview, do feel free to reach out and let me know. Okay, thank you.
Thank you, Rachel. That was very well presented. So we've got some questions come up. I can answer some of them if you like, but do you want to take first punt, and you can always hand them on if you like.
Yeah, sure. Okay, does NICE guidance currently suggest any psycho interventions to people with MCI? Yeah, I don't know that one, so
No,
if you would
the
like
answer
to.
is no.
Okay. How will the autophotography and photo elicitation the team has presented elsewhere impact the intervention? Okay, so for people who don't know about this aspect, is this in relation to Ellie's project, I assume?
Yes, this is, if anybody is passing the Yvonne Carter building, you're very welcome to go up to the 2nd floor, and you can see these beautiful photographs, which are all over the walls at the moment, because we needed to put them somewhere. Because some of the participants in the intervention, we sort of, Rachel actually facilitates some of these groups, don't you?
Yes.
And we encourage people to show photos in tea breaks and tell people about their lives and about what they're doing through photos. And some people get quite into this, don't they? And some people don't. Yeah. So they sort of send them all in. And that gave us the idea to have a photography exhibition. And they worked with a professional photographer and took some really beautiful works, actually. We had it at the Welcome Collection in September. And that's very much about awareness of the fact that very many people experience memory problems over the age of 60, and many don't want to come forward because they fear dementia. And actually, most will never get dementia. And obviously, the advice is to come forward for help if you do worry you have dementia. But there was also, it felt like there was a real need for an awareness of the fact that so many people are worrying about their memory, which I think comes up in the groups quite a lot, doesn't it? So how will it affect the intervention? I mean, I should imagine if we meet our primary endpoints and the Apple Tree intervention reduces cognition, the manual that we have at the moment has lots of the photos from the pilot in it. And I think that we would use that in part of the sort of promotion of the intervention to make it accessible and to really encourage people to come together, because it makes it quite a nice sort of community, doesn't it, when people share photos. Is there a control group? Well, not in your pre-implementation study. The whole thing's a control group in a way, isn't it?
Yeah, so there's no control group in the pre-implementation study. In the randomized control trial, we do have a control group.
Yes. Great. Okay. Well, thank you very much, Rachel. Right, so last but by no means least, delighted to have Charlotte Kenton with us, also from University College London. And Charlotte is the Programme Manager for the Embed Care programme, which is an NIHR programme grant led by Elizabeth Sampson, who, if you remember right back to the first slide that Karin put up, I think you've now heard of all of us that have just arrived, me, Afia and Liz. So you're going to talk about that work.
Yes.
Well, and in your own right.
In my own right. Thank you very much. So I'm going to be talking about Embed Care, which is a programme grant, a sort of a sister, brother, cousin to Apple Tree Fund under the same initiative. Embed Care is empowering better end of life dementia care. Why is this important? Why do we need this? Dementia is increasing, and the number of people dying with or dying from dementia will also increase. Dementia brings with it high symptom burden, hospital use, and health and social care costs, which are more likely to increase as people head towards the end of their life with dementia. Care needs to be appropriate for those who are dying with or dying from dementia, and this is what we hope to contribute to through Embed Care. A little bit of background to Embed Care, as Claudia has already said, Liz Sampson, who's a consultant liaison psychiatrist, recently joined ELFT, leads Embed Care, and we're sort of half and half between UCL and King's. It's the largest ever study focusing on end-of-life care for people with dementia, and it started in 2019 and will run through to 2025, and it's approximately sort of £5 million, so it's a substantial grant. The key aims are to leverage step change in palliative dementia care, create a new network for care, engagement and research, and through research we have 4 RAs who are also doing part-time PhDs. The idea is we sort of bring through the next generation of researchers. Another aim is to develop new knowledge and pilot a model of care to empower people with dementia, carers and staff to identify and act upon changing physical, psychosocial and spiritual needs, addressing these across settings. So our pilot model of care should in theory work in the home, care homes and hospitals. This is a very nice, neat diagram of what we thought Embed Care was going to look like. COVID stuffed things up a little bit, let's face it. So the idea was that we'd have these 3 work streams to begin with. First one's basically systematic reviews. Second one is looking at large data, around 20,000 people looking at transitions in inequalities of care. And third one was new cohort study data. So a large main cohort, which I'll move on to, and 2 other pilot cohorts. One focused on prion disease, so probably most commonly known through CJD, and another pilot study in the form of a PhD looking at frontal temporal dementia. All of this new data would then go on to a data synthesis. Unfortunately, we couldn't do that in full as we'd intended, so we had to use other sort of available secondary data. And then this led on to co-design of the intervention, which is sort of roughly where we're at now. And then we'll move on to a feasibility and pilot trial of what we're terming the Embed Care framework. We also have a very enthusiastic and very engaged PPI element that's really keen in being involved, and they've been with us pretty much from the start. That's people living with dementia and those who've been carers for people with dementia. So we get sort of that expert by experience aspect. And we also have an engagement and impact side with public and policy engagement. So the cohort study itself, this is the main cohort, is looking really to identify unmet palliative care needs and the association of those unmet needs and comfort, quality of life, service use, etc., that you can see on the screen. The inclusion criteria are people with a diagnosis of dementia who are aged over 65, and we're recruiting through an unplanned hospital admission. We're also, where possible, recruiting a family carer as well to take part and include their data as well. And to date, we have recruited 91 people living with dementia and family carers. I have to say, those living with dementia, we are collecting data via personal consultees, as most don't have capacity to take part themselves. And data collection is baseline, and then every 2 months over a 12-month period. Recruitment is open at Barts, and the liaison team is supporting recruitment and working with the Royal London Liaison Psychiatry team. So local implications for this. three areas here, I think: data, practice, and research. So data, we're getting new data about experience of people living with dementia and family carers. And because recruiting through Barts, specifically the Royal London, obviously based in Tower Hamlets, we're certainly picking up sort of the local population, which they're often quite diverse communities who may not have been represented in previous dementia research. In terms of practice, I hope the data and the Medcare as a whole will improve dementia end-of-life care by applying results to practice, and also inform local mental health services provision. And in terms of research, so contribute to increasing involvement of local people in research, in this case, dementia, people living with dementia and their carers, and also further strengthen relationships and capacity between ELFT, Barts, and QMUL. Just to acknowledge at the end, there's a protocol if you would like to read more about the study as a whole. It's not just me doing all this, there's a massive team, workstream leads, senior members of the team, and RAs and steering groups, etc. A website, email if you'd like to get in touch, and the disclaimer. Thank you.
Thanks to all of you to coming along, to keeping the interest in research in the audience and at home. I think the test case for this hybrid kind of arrangement still needs to be seen. We've got the left flank kind of still to be filled, so we will see if we continue to do so. But I would also like to say a big thank you to our board. We've got two board members today attending, Paul and David. And I think the board's commitment towards research, retaining really the goods in research, the resources, but also all the logistic and just really content support is really important for research. And I think the breadth really of research that's been presented today is quite telling, because the Trust's provider portfolio has changed, and so I think has the range really of clinical academic researchers that now working with and through the Trust. And I'm very pleased actually that particularly the age range really that's represented in our research has significantly changed with our old age psychiatry camps and colleagues, but also learning disabilities as another important topic, now much better represented. So as usual, just a few, no, this doesn't work. Let's have a look.
Changing the Mensi instead of this.
Oh. Karin, any help? So as usual, just a few comments in terms of what's on the horizon. In terms of the diversity agenda, we heard a lot about research that's relevant for our disadvantaged communities. We had a session this morning on inequalities and how the psychosocial care agenda can really help us to move forward. The Trust has become a Marmot Trust, and that will give us new impetus in terms of addressing inequalities through research. And I'm very pleased to say that the Unit for Social Community Psychiatry goes from strength to strength. Vicky Bird has just succeeded with an NIHR grant, huge grant, and will direct or co-direct a new global health research center. So the kind of the cross-fertilization will continue in that respect. We are in negotiation, I mean, fairly advanced negotiations with one of the leading universities in the country to also have a co-chaired unit that focuses on research in primary care. So that's hopefully something we will be able to present at next year's event. And I guess that the whole STP developments, NL&B and CAPE perspectives will also come into play and underpin really some of the applied research agendas that we've been pursuing for some time. And also in terms of the clinical engagement, Karin was talking about the research champions and how important these are in terms of our reach into services. For the clinicians who are interested in research, who would like to be more skilled in getting involved, we've developed now a research skills training schedule for 2023, which is a rolling program. And there are lots of opportunities, as mentioned early on by Steve, for staff to get involved. MRC or NIHR clinical academic research partnerships offer opportunities for staff to get involved. And the most recent developments that we've actually developed or set up a working group that looks at big data, routine clinical data sets. They are becoming increasingly available, and the data quality has improved. And so we're hoping that it gives us also new opportunities for research. I don't know why I'm so unable to move this. I was supposed to remind you all that we need your feedback. We would like you to complete the feedback survey online. There should be a link, and I don't know if this has been posted otherwise as well, Karin. For more on our health and care research at ELFT, obviously look at our website. There are a number of people I would like to explicitly thank. Starting with obviously all the patients, carers and staff who supported research over the course of the year. Steve Gillard and Claudia Cooper, who have been chairing this quite precisely. I can't remember an event that's been so sort of tightly managed in terms of the time schedule. Support partners for the networking stores. Obviously, you've seen some of them over at the cafe. Charmin, I don't know if she's still here, and Steph Carter, all the people sort of behind the scene. Lots of work goes into these events. And also to mention Karin Albani, who's been holding this really over the course of the last few months. So finally, if you could give us the next slide, please, the note for the next year. So we've got already a date, the 1st of November, 2023, again in person, and we hope to see you all. Thank you very much.